Human neuroanatomy is a dense, three-dimensional tangle of overlapping vascular territories. But when a patient arrives with acute focal deficits, you do not have the luxury of time to untangle it. Every minute an occlusion persists, nearly 2 million neurons die. You cannot reference an anatomical atlas in the middle of a trauma bay. The clinical environment requires a heuristic, a reliable mental model that is instantly accessible when the stakes are highest. This is the stroke stick person. It bypasses the topographical complexity of traditional imaging by replacing the nervous system with a single, highly structured drawing. To map the brain's arterial territories, we are going to systematically subject this avatar to a series of specific, catastrophic ischemic events. Internalizing this simplified model is the most efficient way to translate a chaotic clinical presentation into a precise, actionable anatomical target. We begin with the cortex, specifically the middle cerebral artery, or MCA. The lateral surface of the brain supplies the territories governing the face and arm. We map this by shading the lateral head, the face, and the upper limb in blue. An occlusion here produces profound contralateral face and arm weakness, typically leaving the lower body relatively spared. The MCA also controls higher-order cognition. If the stroke hits the dominant left hemisphere, the patient suffers aphasia, a severe disruption of language. A strike to the non-dominant right hemisphere produces hemispatial neglect, where the brain actively ignores the left side of the patient's physical reality. Moving inward, the medial frontal and parietal lobes are supplied by the anterior cerebral artery, marked here in red. Because the medial homunculus maps strictly to the lower body, an ACA occlusion triggers stark contralateral leg weakness and urinary incontinence. This damage extends to behavioral circuits. Patients exhibit frontal release signs ranging from physical grasp reflexes to abulia, apathy, and drastic personality changes. Finally, the posterior head zone maps to the posterior cerebral artery, or PCA. This feeds the occipital lobe, the inferomedial temporal lobe, and deep relays in the thalamus. A PCA strike severs visual processing, causing contralateral homonymous hemianopia, the loss of exactly half the visual field. When the temporal lobe is compromised, it is accompanied by severe memory impairment. PCA strokes present with this specific combination of dense vision and memory loss without major motor weakness in the limbs. Look closely at this graphic showing the dashed lines separating these three major territories. These are the watershed border zones. During states of severe global hypoperfusion, such as cardiac arrest or hemorrhagic shock, the farthest reaches of these arteries fail first. This starves the proximal motor tracts, creating the classic man-in-a-barrel syndrome, characterized by weakness in the shoulders and thighs. If a patient shows unified motor and cognitive deficits, isolated strictly to one side of their body, the pathology lies in the cortex. You are hunting for an occlusion in the MCA, ACA, or PCA. Once we move below the cortex and into the brainstem, the topography flips. The logic shifts to the rule of crossed signs. Brainstem pathology is identified through the combination of cranial nerve deficits on one side of the face and weakness or sensory loss on the opposite side of the body. A strike to the lateral medulla causes Wallenberg syndrome. The physical markers are highly specific: a hoarse voice, a compromised swallow reflex, and an ipsilateral droopy eyelid, known as Horner syndrome. Compare that to medial medullary syndrome. Here, the tongue will visibly deviate straight toward the side of the lesion, accompanied by contralateral body weakness and a complete loss of vibration sense. Moving to the posterior fossa, cerebellar strokes present differently. They cause violent vertigo, severe ataxia, and nausea, distinctly without profound weakness in the arms or legs. These are intensely dangerous. Cerebellar tissue edema expands within a tight, rigid space, compressing the fourth ventricle and medullary centers, causing sudden respiratory arrest. Deep inside the brain's internal capsule and basal ganglia seep to tiny penetrating arteries. Infarctions here cause lacunar syndromes. The diagnostic rule for a lacunar stroke is purity. They produce exclusively pure motor or pure sensory deficits. Because they sit far below the cortex, you will find zero cortical signs, no aphasia, no neglect, and no visual field cuts. Identifying these crossed signs or pure tract deficits immediately eliminates the upper cortex from your differential, focusing your search entirely on the brain's deep structural infrastructure. The highest stakes scenario in vascular neurology is an occlusion of the basilar artery. This section details the catastrophic late-stage presentation, locked-in syndrome. The patient's entire motor system is frozen, leaving only awake eyes, followed by inevitable progression to coma and respiratory failure. Treat any patient presenting with vertigo, an inability to walk, double vision, and a declining level of consciousness as a posterior large vessel occlusion until proven otherwise. But ischemic occlusions are only one half of the pathology. If a CT scan reveals an active hemorrhage rather than a clot, the required response radically shifts. This chart lists the rapid pharmacological reversal protocols required for patients actively bleeding while on anticoagulants. The chemical antidotes are highly specific. Warfarin requires 4-factor prothrombin complex concentrate and vitamin K. Dabigatran demands idarosuzumab, and X inhibitors require andexanet alpha or PCC. Having these reversal pairings mapped out ensures immediate readiness for hemorrhagic emergencies. This brings us to the completed stroke stick person. In a high-stress scenario, you deploy this model using the whiteboard read order, a disciplined top-to-bottom mental scan of the patient's deficits. You check the upper cortical territories first. Vision loss points to the PCA. Weakness in the face and arm, or speech deficits, indicate the MCA. Leg weakness and frontal behavioral signs isolate the ACA. Then you move down the body. Crossed signs localize to the brainstem. Severe isolated ataxia points to the cerebellum, and bilateral weakness with low consciousness warns of the basilar artery. By memorizing this single schematic, you bypass the complexity of a neuroanatomy textbook. You translate a tangled web of physical symptoms directly into a vascular address, saving time and saving brain.